segment is about the health and medical information for the internationally adopted child. The information included is general, current adoption knowledge. It is not medical advice. Please consult closely with a medical doctor about your specific situation. Because the internationally adopted child will have some specific medical needs, it is wise to begin early researching and choosing a pediatrician. Considerations you may make to help with choosing a pediatrician include asking other adoptive parents who they use and if they're pleased. Find out whether the doctor has much experience or specialized training with internationally adopted children, and if so, from which countries. Will the doctor review the referral report? If so, what fee is charged? How soon will the doctor expect to see the child after arrival, and what tests will they recommend? What are the doctor's feelings about bonding and attachment for adopted children? Does this match my feelings? Most doctors are great about this. However, I've also heard some advice from doctors that may work well for biological parenting, but could be terribly harmful to a child in an early attachment relationship with an adoptive family. It's a good idea to have the child evaluated by an international adoption medical professional or at an international adoption clinic. Your placement agency may be able to provide a list of contact information for these specializing physicians. These doctors have experience with the unique issues of international adoption and health and have evaluated many adopted children. They are usually able to identify red flags in referral information, and they have a lot of experience reading the sometimes unusual styles of medical assessments from other countries. At minimum, you should consult with a pediatrician or local doctor about your child's referral information before acceptance. But using an international adoption medical professional is always encouraged. Common medical concerns of the internationally adopted child include rickets, lead poisoning, anemia, syphilis, tuberculosis, hepatitis B and C infection, HIV, intestinal parasitic infections, scabies, malnutrition and failure to thrive, iodine deficiency, and incomplete immunizations. The emotional and psychological health of the child may also be affected. Children in orphanage care may have little social interaction with healthy adults or little stimulation, and their needs are not always met on demand. Many will not have a consistent caregiver, and emotional and psychological development can be disturbed. It is possible they could have been victimized by a caregiver or an older child. In general, the more time a child lives in an orphanage, the greater potential the child will have for emotional, physical, and/or transition problems. Internationally adopted children may also have difficulty with sensory integration, attachment development, and post-traumatic stress disorder. Blood screening tests are used to determine if the child has or perhaps was exposed to some infections, usually including HIV, syphilis, and/or hepatitis. And this information is usually provided with the child's referral information. If the results are negative, please remember there is no guarantee that the child may not be exposed to the disease after the test was taken. However, you can be generally assured that it is unlikely the child will actually have one of the tested diseases. These tests are usually repeated upon the child's arrival. Internationally adopted children may arrive with skin parasites such as scabies or lice. These are also very treatable, but sometimes all family members will need treatment as well. Intestinal parasites are also commonly found in institutionalized children. Giardia infection is found in the stool specimens of many children. It is easily treated after the child comes home and sometimes treatment for the whole household is needed. Giardia can be considered similar to head lice in seriousness of illness, contagion, and treatment. Fetal alcohol exposure is a common risk factor in Eastern European countries, but it can happen for a child adopted from any country if he or she was exposed to alcohol during the mother's pregnancy. Although there is no one specific test to determine exposure, some common characteristics of prenatal alcohol exposure include small head circumference and brain size, or microcephaly, mental retardation and developmental delay, abnormal behavior such as short attention span, hyperactivity, poor impulse control, extreme nervousness and anxiety, visual difficulties, slow physical growth before and after birth, distinctive facial features such as flat nasal bridge, thin upper lip, short upturned nose, smooth skin surface between the nose and upper lip or missing philtrum, and small eye openings. Prenatal alcohol exposure usually cannot be conclusively diagnosed prior to the child's arrival. However, physicians will consider the above characteristics and, along with the child's social and medical reports, pictures, and hopefully a videotape, to discuss with you the child's risk. Further, there is growing research available on the effect of other substance exposure during pregnancy. An adoptive parent should speak with a doctor who is very current and informed about this history to explore the short and long-term risks to the child. Difficulty with sensory integration may occur if babies are unable to explore their surroundings, or if their vestibular and proprioceptive senses were not fine-tuned as infants through loving interactions with their caregiver. This disorder can be successfully treated with an occupational therapist, but not all children will fully recover. In the segments about trust-based relational intervention and sensory issues, you will find more details about how these senses develop and how you may help your child who has problems with sensory input. If the child has had a positive skin result for tuberculosis, usually it is not found to be an active infection of the lungs, but that the child has been exposed to the bacteria either through contact with an infected person or through administration of the BCG vaccine. Physicians will perform an X-ray to ensure the lungs are not infected. It is generally recommended that the child take medication for several months to prevent the spread of the disease to the lungs. But this is a decision that will be made with your doctor's guidance. Immunization status is also an important medical concern. Some children may have received some immunizations and others may have received nothing at all. If a child has received immunizations, they may or may not have been given at appropriate time intervals or in appropriate amounts. The immunizations given may have been expired or kept at temperatures inconsistent with American standards. Immunization considerations to discuss with your child's doctor include whether to accept the child's arrival immunization record as sufficient, to run blood tests or titer tests to evaluate the existence and quality of immunizations in the child's body, or to re-immunize. Lead poisoning is also a risk, and children adopted from China appear to have the greatest risk of any adoptive group due to coal burning and lead-containing gasoline. Lead poisoning can affect the brain and kidneys and may cause learning difficulties. However, in time, lead dissipates from the body, and as long as there's no additional exposure, children can usually become fully healthy.
Dr. Melissa Goldstein graduated from Cornell University Medical College in 1999 and completed her internship in pediatric residency at New York Weill Cornell Hospital in 2002. She then practiced medicine in Russia for 4 years as a pediatrician for Moscow's large expatriate community A significant portion of Dr. Goldstein's practice is devoted to adoption medicine and pre-adoption medical counseling. Dr. Goldstein is board certified in pediatrics and is certified as a child, infant, and adult CPR instructor. She currently practices medicine at Carnegie Hill Pediatrics in New York City.
Well, it depends on the country. Every country gives you a different amount of information, and of course, you sort of get a sense of what each country is going to give you. And then when you don't get that information, it sort of perks up your curiosity even more. Why aren't we getting this time? But so different countries give different information. I generally always get some measurements. So either there'll be birth measurements and current measurements, or sometimes depending on the country, like for example Korea, you'll get measurements monthly. Maybe they're every 3 months. So that was the way Russia was. And you'll also get, and again, this is different depending on the country, if there is a birth mother that we know about the birth mother, we'll get some data on her. We almost always get blood work, and the blood work usually includes hepatitis B, hepatitis C, HIV, and syphilis. If the child's a foundling, obviously we'll have less information on birth family. I would say with most countries, we almost never get any information on birth father, with the exception of sometimes Haiti and Ethiopia, where the birth families are somewhat involved. Ideally, I would love if they've had some checkups and seen some doctors and I would get the medical report from that, but that doesn't always happen. But I do tend to get some developmental information. So if the child is a 1-year-old, are they sitting? Are they babbling? Are they crawling? So I'll get some degree of developmental information, and that's super valuable to me. I mean, in some cases, in almost all cases, you'll at least get a photograph, and in some countries, you'll get a video as well, which is super valuable. I don't think anything is purposely incorrect, but I think the orphanages tend to be the staff tend to be quite overwhelmed, and as a result, sometimes the information isn't coming as quickly as we would like and may not be with the accuracy that we would like. But I don't think anything is on purpose or they're trying to be deceitful. But I think it's a product of them just being overwhelmed. Medically, maybe they don't have the chance to take the children to a doctor. Blood work wise, I think we pretty much always get blood work, so somehow they manage to do that. But any limitations that we see, I think, are really a result of them not having enough resources. They tend to be really overwhelmed. Depending on the orphanage, I mean, you can have one caretaker taking care of 15 kids. I mean, it could be even more than that. I mean, so if the ratio of caretakers is a 1 to 20, it's hard for her to keep track of measurements and send them on time and maybe send them so accurately. We do. We put them into one of 4 categories. Let's call them 1, 2, 3, 4. 1 being average risks, which means that there's no red flags above that which we can't see. So of course there's risk going into an international adoption or any adoption. There's risk going into a regular birth, a biological birth. But if there's no risk that we see above the unknown, then that child will go into the average risk category or the lowest risk category. If there is a red flag, and a red flag might be a head circumference that's plotting below the curve. Another red flag may be a 12-month-old that's not sitting up on their own, or a 12-month-old that's not making any babbling sounds. These may be things that I would consider a red flag. If you have one red flag, it puts you into the second risk category, which we would call, when I was trained, Jane Aronson would call it a mild. So we can call it a mild. If that confuses people, sometimes we just call it the second risk category. And then if you have 2 red flags, then you would go into the next risk category, and then anything above 2 would put you in the severe risk category. and these are things that we can see. Of course, like I said, there's risks that we can't see because you can't predict how a child's going to end up. But if you do have a head circumference that's not meeting the normal range, it's going to put you into a higher risk category than if the head circumference was in the normal range. If you have a child whose birth weight was well below the curve for that gestational age, that's going to put you into a higher risk category. And what does it mean to be in a higher risk category? I think you have to consider that that child may be at greater risk of having cognitive problems and developmental delays, or whatever they may be. But we're talking about cognitive problems for the most part. It depends what she's doing. I mean, obviously, it'd be better if she was eating well, but a lot of the kids in coming from Haiti and from Ethiopia, that's the main problem, is malnutrition. That's probably less worrisome to me than, say, a mother who was, was eating a good diet but was abusing alcohol or drugs or had some sort of congenital infection. So, malnutrition is not ideal, but it is, of all the things a woman can do during her pregnancy, it's less of a concern to me. The good thing about nutrition and malnutrition is that you can see how the child does over time. And for the most part, we're not talking about adopting newborns. When we're talking about international adoption, we're talking, depending on the country, we may be talking about a 12-month-old and up. So that child should have already caught up. So even if the mom was malnourished during her pregnancy and the child was born with a very small birth weight because of her malnutrition, we can see that child has or has not caught up, so that the risk assessment will be easier to get and to do it more accurately because of that 12-month interval. Or in some cases it may be a 4-year-old whose mother was malnourished during her pregnancy, but now the 4-year-old is thriving. So I really, it doesn't bother me. In fact, I care very little about her nourishment during her pregnancy if I could see that the 4-year-old is stellar. Well, it's Russia. It definitely has a lot, but now I do a lot of domestic adoptions here in the United States, and I see a lot of substance abuse during pregnancies here. It depends on the substance. Alcohol is, I think, everyone's least favorite teratogen. It's the least favorite thing a woman can do during her pregnancy, with the exception of probably some medications. But how much alcohol is too much alcohol, I don't think anybody knows. I mean, my liver and your liver may metabolize alcohol differently. One drink to me is different from one drink to you. So, even though alcohol is our least favorite thing, it doesn't mean that every woman who drinks alcohol is going to have a baby with fetal alcohol syndrome. So we really have to look at the big picture. But alcohol is certainly something that we don't like. Surprisingly, there are certain things that a woman can do during pregnancy which sound awful, but they really don't get me that jazzed. For example, in Russia, heroin is a big problem. Opiates are a problem here. Heroin and opiates of that sort really don't seem to have any long-term problems for the baby. They do in the short term, so a baby can be born addicted to methadone and addicted to heroin, but we can do a wean, which may take 2 weeks, may take 4 weeks in the hospital, and that baby can be perfect after the acute withdrawal period. So heroin, scary, sounds awful. I would really rather see a heroin abuser over an alcohol abuser. Cocaine, methamphetamines, cigarettes, these are all things I would rather these women don't do, but I wouldn't write those babies off without really exploring more, because I think they sound a little more scary than they may end up being. Listen, I don't want anyone to do these things during their pregnancy, but there are worse. It's certainly a spectrum of what a woman can do and how it can affect the baby. It's not that every mother who tried cocaine during her pregnancy that we have to write off that child, because we've seen healthy, thriving babies born to mothers who did a little bit of cocaine, and we've certainly seen, in my experience with Russia, a ton of babies born to mothers who were IV heroin users who had hepatitis C, and the kids come out beautiful. They don't have hepatitis C. They just are thriving and in mainstream schools, and you would have never known. So, you really have to look at the big picture and what the woman's doing. Certainly in Russia, alcohol and heroin are your big ones. When you go to Haiti or Ethiopia or Congo, and these are countries that you don't see drugs and alcohol there. It's really just not a big problem. Like you said, poverty and maybe, certain diseases like malaria and tuberculosis, but not really substance abuse is really not a problem in that. When you're talking about domestic adoption and you're talking about, then you're talking about all different things. Then you're talking about methamphetamines and you're talking about heroin and you're talking about alcohol and you're talking about any possible thing here. When you're talking about Asia, I think you see a little bit more alcohol versus any other strategy. But most of the African countries that people are adopting from, this substance abuse really isn't a big problem, or at least in my experience, it hasn't been. The malnutrition and the sickness is more of a problem. Well, I think in general, people think that foster care is more ideal than than orphanage living. Of course, it depends on the foster family. I mean, if you had an abusive, non-caring, non-loving foster mother, that wouldn't obviously be very good for the child. Although I think that's kind of a rare situation. Most of these foster mothers that we've seen working for the agencies have been around for a long time, and they've been doing this for a long time. They've been really well screened. So in general, I think a foster family really promotes intimacy and allows the child to develop a relationship which sort of resembles somewhat of the relationship that they're going to experience when they get into their adoptive family. With that said, I mean, you can have amazing orphanages. They're not even really called orphanages. We call them baby homes or foster homes because they're so amazing. I mean, that is certainly was the case in certain orphanages in Russia. It is certainly the case in certain orphanages. I don't even like to call them orphanages in Ethiopia and Haiti. You get to these homes and I mean, they're so loving, so loving. And these are homes that are run by the agency, and so they're on top of it. They're making sure these kids have the right food. They're making sure that any sick kid is immediately brought to a doctor. To call it an orphanage is really almost like a disservice. There are orphanages that are not good, that is for sure, and they exist in every country. Certainly in Russia, there are some orphanages that you walk out of and the smell and the kids sitting around and rocking because they need stimulation, and certainly in some of the government-run orphanages in Ethiopia, it's really sad and it doesn't look good. But in general, I think, and I don't want to generalize too much. I think people prefer foster care living because it mimics the lifestyle that the children are going to have in their adoptive home. A little bit in the area of speech. That's probably the largest delay that we see is a speech delay. And that may be because I think speech develops when a child is talked to in the face. You're really eye contact and talking to them, and whether it's ba 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 in their face, I think that's missing when a caretaker is overwhelmed by the number of children that she must care for. In a foster care setting, in the majority of foster care settings, it's not like that. The women do have, and there's a mother, a father, and siblings, and this is what they do. This is how they earn this is how they have a livelihood. They work for the agency and they foster children, and they're good at it, and they're talking to the children constantly. They're not overwhelmed. So I think, if anything, the only area where I see a difference is in the area of speech. That if I see a speech delay in say for example, a Korean baby that was fostered, it's not the norm. Whereas if I see a speech delay from a kid who was in an orphanage, even a stellar orphanage in Ethiopia or Russia, it's more the norm. So it doesn't frazzle me too much because I know these kids are going to catch up and do fabulously. But it's more uncommon to see that speech delay from a kid who was in a foster family, I think. Usually when I see children, I see them within the first week that they've been home. When we like to do that because for the most part, we don't know if they've had any vaccines or or what infections they're carrying and whatnot. So first we go over, and we just go over basic age stuff. A lot of these are first-time parents that are coming to the office. So first we just go over norms for that age. And then we go into the specifics of what the child should be having now that they're a new arrival to the United States. Some of it varies a little bit with country, but for the most part, I like to get every child to have a formal hearing test. Now in the United States, every baby, once they're born, right away before they get discharged from the hospital, has a newborn hearing test, a newborn hearing screen. So I feel that every child should have that. So even if the parents have no concerns about hearing, I get a formal audiologist to see them, preferably a pediatric audiologist to see them and do hearing evaluations. We also do a formal vision evaluation, which if they're real young has to be done by a pediatric ophthalmologist. As far as stool studies, we do pretty thorough stool studies. We ask the parents to bring in 3 separate stool samples from 3 separate days, and for those we're testing for Giardia, amoebiasis, any ova and parasites, and then also we do some stool cultures. The Giardia is pretty much comes up 90 to 95% of the time from Ethiopia and from Congo, so it's pretty important that we catch that. As far as blood work that we do, we test for the titers, which means that a lot of these kids come back with really good looking vaccine records, but we can't take anyone's word for it. So we go ahead and we test for titers, which means that we test their blood to see if they've indeed been vaccinated against the tetanus, so that they should have immunity to the tetanus. If they do have immunity to all the things that are on their vaccine record, and we literally test for each individual thing, then we'll let them keep those vaccines. If not, we pull them and we start that particular series over. That's how we do it. Other doctors may go ahead and just start the vaccine record all over again and say that they're not trustworthy. But I think it's nicer to, you're doing a blood stick anyway, to just go ahead and check for titers to make sure, to see that they've had those vaccines. And if they have, I see no reason why we can't keep them and take it from there. In terms of our discussion of the child, we do a lot of developmental analysis, seeing what the child could do, playing with them age appropriately. If I have some concerns right then and there, pretty obvious concerns, I'll go ahead and refer to something called early intervention, which is something that at least in New York, we have that's provided by the city, which will offer free services and free evaluation for kids who are exhibiting delays. If I'm on the fence and I'm not sure, I usually will give it another 4 weeks and see the child back in 4 weeks, because the catch up for kids is amazing. Not to mention that some of this stuff is language dependent. We'll try not to be too language dependent, but a lot of the times kids that are coming from China may not be saying anything because they're so overwhelmed with the English. But I think that if I'm sure right off the bat that there are going to be some needs, then we'll go ahead and involve the early intervention program, which is an evaluation of speech, occupational or fine motor skills, and physical skills. As far as the blood work, just to go back to the blood work for a second, I don't mean to jump around. We do, so I mentioned that we do the titers. We also repeat, which usually we've already had, as I mentioned, HIV, hepatitis B, hepatitis C, and syphilis, and we do repeat those. If a child is from an African country or any country where malaria is a problem, we'll also add malaria onto that. And every child will be screened for tuberculosis with a tuberculosis skin test. I think that's most of the, we do basic chemistries, we check their thyroid, we check their kidney functions and their liver functions. And for the most part, that's all been fine. But I think those are most of my post-adoption things. And of course, as I said, the audiologist and the eye doctor, I usually have to send them out unless they're old enough for me to do it in the office, which is not so common. I think one thing I would tell people to do is, I think different agencies do different countries, I don't want to say better, but more often, and are very savvy at that country. So I think it's not a bad idea to sit down with your social worker and see what country fits for you, and then choose the agency based on the country. So that's one thing. The other thing is to make sure that you meet with somebody who does this kind of thing, that will go over the medical with you just to prepare you, because there are a lot of medical issues. Some of them sound scarier than they actually are. Like an HIV positive parent, an HIV positive mother sounds so scary. But, if she was well treated and she received her retrovirals, the child could have a very low chance of having HIV. And if you have it, you have it. And if you don't, you don't. And that child could be totally fine, but just sounded scary. So I think it's important to meet with somebody about these issues. It might just be your pediatrician, it might be an adoption doctor like myself, or it just, somebody who knows what's going on. Somebody who knows that a mother who did heroin doesn't mean that your baby's going to have all these problems. And vice versa, a mother who had, who acquired syphilis during her pregnancy. I think you need to know what that means and what that means for your child. And the only way to do that is just educate yourself. And the way to educate yourself, I think, is to sit down with your medical and with a doctor and go over it. And most agencies now, I think, will push you to do that anyway. But it's important for both to be warned and also to be comforted, because there's just a lot of information in there that you shouldn't be expected to know. Fabulous. I think they're fabulous. I think it's important to hire somebody to go over the medical with you, especially if you're a first-time parent, you have no exposure to children. I think it's important to have someone review the medicals, which includes usually a picture, possibly a video, and some developmental milestones that the child's hit, plus all the blood work that we mentioned. Which, by the way, I also should have said, we also screen for anemia and lead. We always have to screen for lead when we get the kids over here. But I think it's important to have somebody go over that stuff with you and put a child in a risk assessment category, because you have to make sure you know what you're getting into, and you certainly have to not take on something that you can't handle, and you want to be prepared. But I think if you do it right and you sit down with somebody and you really go over the information that you have, I think you can have a fabulous outcome. Like I said, probably because the people I'm seeing did use some kind of adoption specialist to evaluate the children. The kids in my office that I see, and it's probably maybe 50% of the practice, are fabulous. Yeah, some of them need speech and some of them need some help, but they're thriving. And some of the there are a lot of horror stories, and those are true stories. I'm not denying that those are true stories, but they really sort of overshadow the great stories for some reason. In the news, it seems really interesting to talk about that 7-year-old that was put back on the plane by his American parent back to Moscow because she couldn't handle him because his behavior was so awful. Those stories sort of take over. There are so many stories of kids that are amazing and that are doing amazing things, and the families couldn't be happier. And I think if you do it right and you sit down with somebody, you get all the facts and you really understand what to expect, I think you can have a fantastic outcome. I really do.
Malnutrition and growth delay are also important concerns. Growth failure may be due to undernutrition, intermittent transition, emotional deprivation, or lack of stimulation. Growth failure can interfere with normal physical and mental development. Iron deficient anemia is caused by malnutrition, and iodine deficiency is a concern for children adopted in areas of the world such as very rural China, Mongolia, or Tibet, where iodized salt is not part of the diet. Iodine deficiency can cause hypothyroidism. Proper nutrition is especially necessary during the child's first 2 years of life. However, children are resilient and have much potential to recover from poor nutrition and catch up in weight, height, and even head circumference. Rickets, a deficiency of vitamin D, calcium, and phosphate, are also a possibility due to poor nutritional intake and lack of sunlight.
Michelle is a pediatric speech-language pathologist specializing in the communication and feeding of children with severe disabilities. She is currently the CEO of SwitchClimber.com, an educational company that operates an interactive website for children who cannot access typical computers. Michelle adopted her daughter, Baka, at age 5 from Kazakhstan. She became passionate about the need for improved orphan nutrition after witnessing Baka's traumatic recovery from debilitating rickets within weeks of receiving vitamin supplements. The mission of Spoon Foundation is to improve the nutrition of orphaned, fostered, or adopted children so that they can grow and thrive. Their goals are to give as many orphans as possible the chance for healthy development, influence nutrition policies and procedures for orphans around the world, ensure that adopted children get the nutrition they need once they come home.
Well, in 2006, when Cindy Kaplan and I each adopted our children, we were shocked at the degree of malnutrition our children had, despite the good care that we knew they'd received in their respective baby homes. And we were so moved by their conditions that we wanted to help in some way. So we started reaching out to international NGOs to find an organization that addressed nutrition of children living in orphanages, and we couldn't find anybody that addressed that. So that's basically why we started Spoon Foundation, with the mission to improve the nutrition of children living without families. And we engaged a lot of influential professionals and organizations in our medical advisory board and through our partnerships, people like Dr. Dana Johnson, Dr. Julian Davies, partners like Joint Council and Holt. And with that engagement, the word started getting out about the importance of nutrition for this population. And then about a couple years after we started Spoon, we completed the first ever study of the nutrition of children living in institutions. And those findings highlighted the extent of malnutrition in this population. So prior to the study, many people believed that the nutrition of children in institutions in developing countries would probably be better than their peers living in families, because at least kids in institutions usually had 3 meals a day, their menu was overseen by the government, but that turned out not to be the case at all. It turned out that kids in institutions had much higher rates of anemia, vitamin D deficiency, stunting, wasting, being underweight, all those things that indicate malnutrition. And so because the state of their nutrition was highlighted, I think more and more people are becoming aware of the high risk that kids in institutions have for malnutrition. We're believing, although this isn't completely studied yet, we're believing it's a combination of poor nutrition and poor nurturing. Mm-hmm. And there was a study done in China where the nutritional status of kids was measured and kids who were getting a lot of nurture, and it was compared to kids who were not. And surprisingly enough, the kids getting a lot of nurture didn't grow as much as would have been expected. And what was missing from that study was the kids were not getting improved nutrition. So what we're starting to see and believe is that kids in institutions are not growing as well and have a larger percentage of micronutrient deficiencies because, one, they're not getting the love and attention and nurture they need, and two, they're not getting the good diet that they need. They may be getting enough food, although often not. It's surprising when you think they're getting enough and then you measure it, they're not. But even if they are getting enough food, it's probably not the right kinds of food. Many reasons. And it starts even prenatally. So it might be that their birth mother had inadequate prenatal care, a poor prenatal diet. Many kids who live in institutions may have had low birth weight. They might have been premature. And then, as we all know, kids in institutions are not breastfed. They're sometimes given formula, but not even always formula. Sometimes they're started out on animal milk right away, whether it's cow's milk, buffalo milk in some countries, mare's milk in some countries, and that kind of milk does not have the nutrients that babies need. And then even when they get formula, sometimes the formula isn't fortified the way that formula in the U.S. would be, or oftentimes it's watered down and diluted to stretch it out more, and then they're not getting the nutrients they need. A lot of institutions introduce solid foods too early to kids. For whatever reason, it might be a cultural reason, it might be to save money, it might be they don't have enough formula, and so kids are getting solid foods too early, and that means they're not getting the nutrients that they're supposed to be getting from the formula. And then it might just be what we would commonly think, that the orphanages don't have the amount, the necessary food, so kids aren't getting enough, or the food they're getting doesn't have the nutrients that they need. And then there's feeding practices. I mean, there are just so many reasons, but what we've seen, universally in the orphanages that we've gone to are inappropriate feeding practices that lead to malnutrition. One that a lot of people are familiar with is bottle propping. Bottles are often propped, and you can imagine what that means. The bottle might fall on the floor, and then the baby misses a meal. It might drop out of their mouth, and then they don't get enough. They might actually get too much because there's these big, huge holes in the nipples, and they get too much in and end up with ear infections or pneumonia because fluid gets into their lungs, and then they're sick and they don't get nourished. And other feeding practices, we often see kids fed from behind. The caregiver stands behind them or sits behind them and feeds them and isn't really paying attention to what's going in their mouth. They might be fed too rapidly, or you'll often see several kids sitting on the floor and one caregiver with one bowl and giving each one a turn, feeding them. And so obviously they're not able to track how much one individual child ate when they're fed like that. Another biggie is lack of time outside, which means lack of exposure to the sun, which can lead to vitamin D deficiency, and which is rickets. And another biggie is just stress, and that gets back to your previous question. When a child is transitioned from their birth mother to a secondary care provider, maybe a third and a fourth if they're in an institution and they move from room to room, or they go into foster care and back, and then they go into their adoptive family. All that stress can just interrupt the natural feeding cycle and lead to malnutrition. And then, just what you said before, not receiving enough attention and love and nurturing means they don't grow. I think it's been shown that if a child receives the same diet over time, but if they're on the same diet, their diet never changes, but they start getting more individualized attention and love and care, they start to grow, which is really depressing, quite frankly, that that's what it takes to grow, is attention and love, which is something, of course, every child should have. Well, we've found that the quality is most often, if not always, poor. It varies from orphanage to orphanage and from country to country, but in general, the diets we find are low in iron, low in micronutrients that one would get from fresh produce, just low in variety. Oftentimes the kids are getting sort of the same meals every day or every week. The formula, as I mentioned before, is often not iron fortified, and the kids don't get it as long as they should. Sometimes it's sort of a cheap local formula, and who knows what micronutrients are in it. And the low in iron that I mentioned is usually the kids aren't getting enough meat. And, as we know in a Western diet, you don't have to have meat to be healthy, but if you're not eating meat, there are ways to make sure you are healthy. And in these cases, kids are usually not eating meat because it's not available, and there aren't other things being done to the diet to ensure they get enough iron. So that's why so many of the kids are iron deficient. Well, if they're lucky enough to be able to ask the questions, ideally they should be asked before the family even travels. That way the family can be prepared by bringing some of the favorite foods and items. But even if they can ask them in country, that's great. And then they could go out and shop there for what's needed. So I think it's very important to find out what a child is currently eating and drinking, and trying to stick to that routine until the family's home, and then making a slow transition once home. Parents are always anxious to get kids on healthier diets and feed them what they perceive to be healthy foods, but sometimes that's too much of a shock to a child's system. So we recommend that a family find out what the child's eating and drinking and try to stick with that, especially if it's formula. Stick with the formula they're on. Try to buy enough in country to last you till you get home, and then make that gradual transition when you're at home, when you have access to your pediatrician. In case there are issues, then your pediatrician's right there, and you're not dealing with the issues in another country without any medical support. So some specific questions. We have a list on our website, and it has just some basic things that you might not think of in the moment, like does the child feed him or herself, and how do they handle utensils? What kind of cup or bottle do they use? Can they feed themselves the cup or bottle? What consistency of food is being served? Oftentimes in orphanages, kids are kept on real mushy food because it's just easier to kind of shovel in. And a child who is, say 18 months, who in the US would be finger feeding themselves, might have never had that experience. So you can't just assume, oh, the What to Expect book says feed this type of consistency because they're this old. You sort of have to start with them where they are. And if they're 9 months old and not sitting up yet because they haven't moved a lot, they may not even be ready for spoon feeding. So you need to kind of see where they are and work from that. And then finding out a meal schedule and trying to stick to that meal schedule. Is it every 2 or 3 hours? What time do they get up? Oftentimes in orphanages, kids have their first meal really early. And then just finding out specific foods that the child likes and dislikes, and maybe even brands. And if there's a specific food they like, what brand is it, and is it something you can find in country to buy some extras to bring home? That's right. Oftentimes kids don't develop that pickiness until they get home and realize they have choices, and that should be seen as positive. I think, a lot of parents get worried that all of a sudden they're becoming picky eaters, but it's really a positive step in their development that they're showing choices, preferences. And, another thing that kids don't often get a chance to do, we're always amazed. Our team has been in many, many different orphanages, and it's very rare that you see a child feeding themselves with their fingers. They'll go right from being fed with a spoon to feeding themselves with a spoon when they're quite a bit older, but they don't get that chance to play with food and touch it. And so that's possibly a stage that's been missed. That's probably a good idea to go back and let a child do, even if they're a little bit older. The two main issues that are usually seen are either selective eating or hoarding, and they're not mutually exclusive. You can see both in the same child. You can see them at the same time. You can see them come and go. So hoarding is, I think a lot of people are more familiar with hoarding and expect that, but it actually seems like selective eating is what we're seeing more of. But hoarding can include anything from stashing food away, like hiding it under their pillow or in their room somewhere, in their pockets. But it also can be things like eating excessive amounts, storing food in their mouths for later. I was actually talking to a parent yesterday who explained that she'll find food in her daughter's cheek like 3 hours later, something from a meal. And it's not that the child can't chew and swallow it, she's just saving it. And just hoarding can also be just a child who wants to eat all the time and is really, really stressed about it and is always in the kitchen, kind of bugging you and asking you when the next meal is. And then you kind of have the opposite extreme, although again, they co-occur, and that's selective eating. And that's a child who accepts a very limited diet and might have difficulties with whole categories of food. So we're not talking like your typical toddler picky eater. This is maybe a child who won't eat any meat, won't eat cooked vegetables, won't eat anything with cheese in it, maybe only has like 10 or 12 foods that they'll routinely eat, and might even be restricted to certain brands, like they'll eat this brand of strawberry yogurt but not this brand of strawberry yogurt. They might eat one thing one day and you kind of get excited, but then they don't eat it ever again. They might even develop rituals around food, like only eating out of a certain container or only drinking juice out of a juice box. In fact, we have a family story on our website. Our website has several family stories, and there's the one that's up currently is of a little boy who would only eat food out of bags and not on a plate. And his new mother couldn't figure that out for quite a while, and he wouldn't eat anything, and she was super stressed. And one day she handed him a bag of food, of something from Starbucks, and he gobbled it up. And then she figured out, oh, he thinks food needs to come in a bag. That was just his prior experience. And so you can get real picky eating, and both of those issues, hoarding or picky eating, may take a long time to resolve, and that's I think that's an important message to get across. It's probably not something you're going to fix in a week or two or a month or two, and that's okay. It might be a gradual process. And I think if parents know that in the beginning, then they won't get so stressed, because it can be very stressful to go through as a parent. But I think if you just kind of remove yourself a little bit and follow your child's lead, and don't get stressed and worked up about it, you'll be much more successful in helping them get through it. I wouldn't
Yeah.
get into power struggles. I would let them lead, and there are certain things you can do to kind of set your child up for success if they do hoard. And this also goes for the selective eating too. I think for hoarding, you've got a child with a high stress level, and who wants to eat all the time, and that stresses parents out, especially in our culture where we're always worried about kids being overweight, and that's the message we hear all the time. And yet here's a child who eats. I mean, you will see kids who can literally eat 3 or 4 times more than their parents do in a day. That's stressful for a parent to watch. But some things that can be done, following the child's lead is very important. Also, just setting up a very consistent schedule for snacks and meals. When first home especially, food should be offered at the table maybe every 2 hours, which seems a little bit excessive, but you want the child to learn that food is always available. And then when they've been around a little longer and they're starting to get a little more relaxed, you can stretch that out to every 2 or 3 hours. And then the child needs to see that the food comes from the parent. They need to have, it makes them feel more secure to know that they're not in charge of it and the parent is going to bring them food. But the parent needs to also give some control to the child. So the parent can bring the food to the table, but then maybe let the child, depending on their age and ability level, let the child decide how much goes on their plate, and they get to decide if they're going to eat it. Some children who hoard are also picky eaters, so they may eat a lot, but they may eat a lot of only 2 or 3 things. And so it's okay to let the child decide, I'm not going to eat this today, but I'm going to eat this, and not to get into those power struggles and to do those things that we maybe were raised with, such as you got to have 2 bites of this before you get up from the table, or you've got to eat your dinner before you have your dessert, or clean your plate. You got to sort of let all that go and let the child lead. The only time the parent should really intervene is if the child is eating to the point of throwing up. And that happens. And at that point, the parent needs to obviously cut the child off. But if that's not happening, I wouldn't even cut the child off. Let them eat until they decide they're full. And it's scary. And the first week or 2 of a child doing that can be really scary because you think it's going to last forever. But if you let the child do that, they're going to slow down over time. They're going to realize there's food there and they're allowed to eat it, and they won't keep eating that way. Research actually shows that the more a child's food intake is restricted, the more they will eat. The less it's restricted, the less they will eat. So keep that in mind as you're like biting your tongue, wanting to say, stop, that's enough. If you do that, you set up that stress reaction in them that, oh no, there's not enough food again, or I don't have enough food, and then they want to eat more and they can't let it go. Whereas if you let them figure that out for themselves, they'll eat less. You want to get them to the point where they trust that there will always be food. And you can also, the parent should develop a few reassuring phrases that they constantly say to remind the child. Things like, there's always enough food here, or you can always ask for food, or we always have enough food for you. And just say those over and over again until the child internalizes that. Micronutrients are just the nutrients that we need in our bodies in small amounts. So basically vitamins and minerals. The macronutrients are the ones we need in large amounts, like fat and calories, protein. The micronutrients are things like iron and vitamin D, vitamin A, vitamin C, zinc, those things. And typically if a child is on a balanced diet, they'll get all their micronutrients. For a middle class or upper middle class family in the United States, there's not a huge worry about micronutrient deficiencies unless they're vegan or vegetarian, and then they need to make extra efforts to get iron and vitamin B and stuff. But for a general family, that's not an issue. However, even if you eat a balanced diet and your child comes from a background where they had undernourishment or malnourishment, they're at risk of not absorbing they're at risk because they maybe don't have the stores needed. And so they don't have good iron stores, for example, when they come to the new home. And then even though they're eating a very balanced diet, they can still become anemic. So a family needs to be aware that, first of all, to offer a balanced diet, but secondly, that may not be enough. And even if you offer a balanced diet, if your child had a rough start, they may need multivitamins, They may need specific supplements like vitamin D, possibly zinc, very likely iron, and those are things that the pediatrician can help you determine. Again, you're not going to know without a blood test. And I also would encourage parents not to think, okay, well, my child's iron is low, but we eat a really balanced diet, so they'll be okay. That may not be the case. They very well may need supplements to get them back up to that sort of safe zone. Yeah, and that leads right into that. So what often happens, almost always, is when a child is adopted, they have this booming growth spurt where they just grow rapidly for the first 6 to 12 months home. Part of that is merely because, like we talked before, about the attention. They're now getting attention, nourishment, love, and that alone makes them grow. They're also very likely getting the calories they need and maybe extras. And that's one of the reasons not to restrict your child's intake. Their body really may need it. It may look like they're just eating like nuts, but they're also growing a lot and they might really need it. And they might even get a little chubby at first, but then they get a lot of linear growth and use that. So what happens, why this is important to know is one, so you don't restrict your child's eating, but also when the child grows a lot, they call on their body's stores, their nutritional stores, for that growth. And if a child has, again, I'll use the example of iron because it's the most prevalent. If a child has low iron stores, say they're not anemic, they're tested and they're not really anemic, they're fine, but their stores are low, that's their ferritin, that's low. They grow really rapidly and they call on all those stores and then all of a sudden they are anemic. So while in the orphanage they may not have been anemic, they might have been fine, but then when they came home and grew rapidly, suddenly they became anemic. And this is sort of new information for everybody. Oftentimes kids are given a blood test when they first get home. They're not anemic, and then it's never tested again. Well, in the meantime, they've been anemic for a long time because nobody thought to check after their growth spurt. So it's really important that to check the child when they're first home for iron, vitamin D. We have a list of what to test for on our website. Test for all of that, but then retest in 6 months and continue to retest every 6 months until the child's levels are normal. If after the first 6 months there are no concerns, then you probably don't need to keep retesting. But after the first 6 months, if they come up iron deficient, which happens on a regular basis, then test again after 6 more months until they're no longer iron deficient. And again, that's that rapid growth spurt makes that happen. That's a tricky one because it really depends on the child's special needs, but I think the most important thing for a family to know is that if they're adopting a child with special needs, that child will most likely have unique nutrition and feeding needs that will need to be met. First of all, as many people probably know, there are more and more children with special needs being adopted. So for example, if a child has a cleft lip and palate, depending on what stage of their lip and palate repair they're adopted, they may have special needs. If everything's repaired, they might eat and drink normally and it's not an issue. But if they're in the middle of repair, for example, a common scenario is their lip has been repaired, but their palate has not been repaired yet. And so they may have trouble sucking from a bottle because they can't get the suction needed. And so a parent needs to be prepared to maybe try some adaptive nipples, or to find out, is there one caregiver who really knows how to feed their child and what tricks do they use, and try to learn those tricks. They also maybe need to be prepared to offer their child a higher, kind of a nutrient-dense, higher calorie diet. And their pediatrician can help with that. But very often kids with special needs, again, for example, cleft lip and palate, are very underweight because they've missed out on a lot of nutrition. Another example would be children with cerebral palsy. They're often underweight, and there are a couple of reasons for that. One is they burn a lot of calories because of their movement patterns, and then the other is sometimes it's harder to feed them, so they don't get enough calories in. And so they also need to be fed with a higher kind of nutrient-dense, higher calorie diet. And that's something a lot of families can prepare at home. It doesn't mean special expensive formula. It just means tricks for how you prepare the food. And then, so depending what the special need is, there are things to learn along those lines. But kind of another overriding message would be to meet the child where they are with their feeding. So, for example, again, the general rule is start spoon feeding a child and adding complementary foods when they're 6 months old. So again, that's something you might read in a book. Well, you might adopt a 16-month-old who's not sitting up yet on their own. And they very well may sit up soon once they get activity and attention and movement. But right now, at 16 months, they're not sitting up. They may actually not even be ready for spoon feeding yet. So you may need to not go by the books, but kind of go with where they're at. And then when they're sitting up well on their own, you can introduce spoon feeding. Or maybe you need to figure out a way to help them sit up on their own so you can introduce it. The same is true with foods with textures. If your child has special needs, they may not be able to handle chewing, and they may not have had experience chewing. So just because they're 3, you might not hand them, pieces see what they were eating before, and again, meet them where they are, and then gradually step up to giving them more and more complex foods. We sometimes laugh at Spoon Foundation just because every orphanage we go to, the kids are being fed with spoons like this big. We have yet to see an orphanage that uses not even baby child spoons, but just regular size spoons. They're always these huge, huge spoons. And so, seriously, the kids may have no experience eating with a regular spoon, and they might get grumpy if you feed them at a regular pace with a regular size spoon. They want it all now, hurry up, they're used to that. That's very common. And so there may be a little transition period to getting them to accept what we would consider regular amounts of food. And then, we see all kinds of things with bottles. A very common one also is that the nipples in the bottles are made really large, and that's so the kids don't have to suck very much, and the food just sort of flows in and it goes really, really fast. And so what you end up getting is mouths that aren't really fully developed. You get sort of these low-tone mouths. You'll often see kids with kind of posture with their tongue out and their cheeks sort of hanging there. And that's just because they don't have all the experience sucking and chewing and moving food around in their mouths. And they'll gain that, but you should be prepared that the child may be a very messy eater at first. And that's because they haven't had a lot of experience doing whatever they're now getting the experience to do that they need to do. And that they're probably doing their best, but they may be very messy and they just need time to experience that. Or even learning, some really young children, babies who are adopted, don't even know how to suck out of a bottle, and they may need to learn that.
Yeah.
So again, don't be too worried. If your child can't eat very well right in the beginning, I wouldn't freak out. I would just know that they may not have had the proper experience to even have that opportunity yet. Well, maybe just knowing that the reason they're doing it is because that's what they were used to before, and it doesn't necessarily mean anything's wrong. And just being patient, maybe having meal times in a kind of a quiet, low stimulating environment, dim lights, turn the TV off, and teach them new habits, that meal time's a pleasant place where everybody sits at the table together, which is very important also, family style meals, calm environment, not getting into power struggles. Some of those phrases we mentioned before might be helpful there. Oh, we've got enough food. There's enough time. Kind of some of those. And actually, if you see that when you're in country, it might be good to learn that in the child's native language. A little phrase like that that's reassuring to them, and find out what that is. Got a few websites. One is ours, which is adoptionnutrition.org. I referenced that before. We've got family stories on there. Mainly so families know that they're not alone, and so they can see success stories and see what one family did for such and such an issue and what one family did for another issue. We also have the list of lab tests on there. It's a PDF you can print off. It's the list you take to your doctor for that first initial visits, and it's the nutrition lab tests. It doesn't cover the other ones. We also have handouts on there specific to special needs. We have a section for special needs, and there are some handouts on there that cover like how to make a diet high calorie, or some like the surgery schedule for cleft lip and palate and how to feed around that. It's loaded with information very specific to the nutrition and feeding of adopted kids. Another website that I really like is thefeedingdoctor.com, and that is Dr. Katja Roel's website, and she has on there a book that's specifically for nutrition, it's specifically for feeding of adopted children. She doesn't cover nutrition as much, but the feeding and the questions you asked about sort of when the kids are screaming, what do you do? And if the kid's hoarding food, what do you do? Another good one is adoptmed.org, and that's out of the University of Washington. That's Julian Davies and Julia Bledsoe's website, and there are a lot of, it covers a lot of topics like sleep and behavior and stuff, but there is also a section on feeding and nutrition there too that's really helpful.
Children from any country may suffer from undetected medical problems or diseases. Seldom any information is available about the birth mother's prenatal care, medical, social, or developmental history. Medical exams are given and reports may be inconclusive or inaccurate. Medical evaluators attempt to identify serious medical problems, but some problems may be undiagnosed or misdiagnosed. A child could have any kind of ailment, including malnutrition, parasites, skin diseases, head lice, upper respiratory or ear infections, or more serious conditions. It is possible a child may arrive with a very serious medical problem that later develops into a life-threatening disorder. Children may arrive with a contagious disease that could be transmitted to family members. It may be a simple virus, or it could be something very serious like tuberculosis, hepatitis, or AIDS. Medical techniques outside the United States or other modern countries often do not allow for the comprehensive screening that is available here. A child in seemingly very good health may be placed and later develop a serious medical problem. Children who have resided in institutional care may also suffer from emotional deprivation, which may affect their psychological well-being. Families must understand with every adoption comes a medical risk. All adopted children experience some degree of transition behaviors or difficulty with adjustment, resulting in problems which can range from quite minor to significant. Developmental delays are very common, and it's often impossible to determine if such delays are due to simple lack of stimulation, which is quite correctable, trauma from placement, or due to a congenital neurological deficiency. Significant emotional difficulty from separations from previous caregivers could affect the child's ability to give or receive affection to and from others. During the initial adjustment phase, many behaviors may be seen. The child may experience aggressiveness, depression, bedwetting, sleep problems, food issues, or problems adhering to limits. The child may view the new parent with detachment, disregard, extreme clinginess, or may be indiscriminately affectionate towards everyone. The child may have temper tantrums, be destructive, deceitful, dishonest, or could be overly passive and compliant. Some children repress their feelings of insecurity, and this anxiety may resurface later when the child is older. The child may have experienced trauma in his or her past, such as multiple separations, physical abuse, neglect, or sexual abuse, and such traumas may result in the child's exhibiting ongoing behavioral or emotional difficulties. Generally, the more life experience a child has, the greater risk for difficulty with adjustment to the adoptive placement. Families who decide to adopt children must realize there are no guarantees as to the physical, emotional, developmental, and social health of a child. At this time, please pause the film and discuss the following questions. Are the emotional or medical risks more concerning to me? Can I handle the potential my child may join the family with an infectious disease? What will I do if my child is not as healthy as I had expected or hoped?
Emily Himonitis is a special education teacher, adoption case specialist, and parent of 3 beautiful children through international adoption. In this interview, she and her husband Chris share their experiences with adoption and unexpected medical issues.
I don't think that we ever had intentions of looking and saying we specifically wanted a child with special needs or anything like that. I think our hope was that, we would adopt a child that we could lovingly welcome into our family and become, part of our forever family. And we knew, with the support we had of our family and friends and the love we have of each other and what we wanted to give this child, if they had special needs, we were prepared to give any support that that child would need. That's kind of a blank check. You never really know what may come in the door when you bring that child home. You just have to have faith in each other and faith in God that whatever it is, you'll do whatever you need to do because it's your child and you want to give them every opportunity to be successful.
I think that being a special ed teacher, we spoke a lot about what we were comfortable with accepting, and special needs was not up in that realm of anything that I wanted to spend 8 hours in my day teaching and dealing with and then come home to. I feel very blessed being able to realize that God put a special needs child in our life because I have a little bit more coping mechanisms and understanding of what he needs, but it was not on the radar when we filled out our paperwork. It was definitely as healthy as possible. I think with Anthony, it was difficult because Anthony was our eldest. And so we didn't have any young kids, and we didn't have biological children, so we didn't quite know, we didn't have anything to measure him against. So we didn't know that he was behind right away or that there were issues right away. We just kept loving on him and thinking that things were wonderful. And then at our 18-month wellness check with our pediatrician, his comment was he should have more than 6 sounds. He wasn't even making words at that point. So at that point is where things started. We got him evaluated by First Steps. First Steps noticed that he had a delay in language, so we did 2 years of speech therapy with him. When in the middle of speech therapy is when Nicholas, our second son, came home, and then when we had something to kind of baseline where Anthony should be, it became a little bit more evident that he wasn't where he needed to be, and that there were things going on. And then every year, it's gotten progressively more obvious. So
yeah, different things presented themselves. I mean, after speech, it was occupational therapy. After occupational therapy, it was psychotherapy and trying to understand, his mindset, his moods, his swings. And it's difficult when you're dealing with a child that's 2 and 3 and 4 and 5 years old because there's still so much natural development, right, that happens with a child at that age. And several of the doctors said, look, we're going to kind of treat for these symptoms, but realize that they're going to grow a lot over the course of this year, and a lot of the stuff they may grow out of. And some of it he has, but of course we've come to find out that we believe, and we don't know this 100% yet, we're in the process working with Cincinnati Children's Hospital to find out, but we believe there are some more deep-rooted issues there. And again, at the end of the day, the most important thing is that we find a way to put him in a position to be successful, and recognizing that, if he has different learning styles or his speech isn't always going to be up to par with everyone else, that's okay. It certainly doesn't make us love him any less. In fact, in many ways, it makes us love him even more to make sure that he's not left behind, so to speak.
I think it was hard because when you first bring an adopted child home, it's hard to know, is this an adoption issue or is this a normal kid issue? All 3-year-olds have temper tantrums when a new sibling is introduced. So when Nicholas came home and we first started seeing some of the rage that he was having that began to concern us, a lot of times from outside sources you hear, well, when my younger brother was born, or when this happened in our family. So you start weighing, okay, well, it sounds like it's a normal kid thing. And then you start to ask yourself, well, is this an adopted kid thing? And then it's, well, this is beyond normal kid or adopted kid thing, so now what are we going to do? That's kind of where it all started. We started with speech therapy because a lot of the anger that he was displaying at a young age, people kept saying, well, if he had the words for it, he would be able to verbalize what his needs were. So that's where we started. We started with speech therapy. We did that for 2 years. And after about a year, he had the vocabulary and the words to be able to express needs, and he was still showing some emotional instability.
And immaturity.
Yeah. So from there, our speech therapist recommended that we take a little time off, take a deep breath, and see kind of where to go from there. And our pediatrician then recommended, well, he struggles a lot with things like tying his shoe, a lot of bilateral issues because his
Fine motor skills.
Gross motor skills.
Yeah.
A lot of things. So his recommendation then, our pediatricians, was to go see an occupational therapist. So we took Anthony to an occupational therapist for 1.5 years to work on strengthening his core muscles, in hopes that if he gained a little bit more control of his body, he would then be able to control the rage and emotion that he was displaying. And we did that for 1.5 years, and it helped some. Mm-hmm. But then after, it was in between his first grade year and his second grade year is when, over the summer, he started talking about hurting himself. And that grew to be a grave concern because he voiced it more, and a lot of the anger and self-loathing didn't go away. And so at that point, we were kind of at the end of our rope, and we decided to go ahead and seek help from a psychologist. So we took him to be evaluated there. She diagnosed him with a number of issues, depression, anxiety. So we started working with her. Upon her recommendation, we moved someone that had a little bit more some specialties in different areas. And he's with he's with a doctor right now, a psychologist right now. And he's also going through a huge eval process at Cincinnati Children's in their Learning Delay Center. So that's where we're at the moment.
I thought a lot about this question when you had sent it to us because, I mean, clearly the dealings of having to cope with the fact that you're not going to, God has not chosen you to have biological children, so okay, there's another plan, and our plan, obviously, we felt and believed through lots of heavy prayer and contemplation, was to adopt internationally, and honestly could not be happier about it. The challenge is there every day because you realize that ultimately, physically, they're not your children, so you don't know their medical background, you don't know the challenges that they're facing as children and what they may face later in life. It's an ongoing challenge, and one of the things I know I have had to get over was the image of what it meant to have, like, for example, Anthony, my firstborn son, there's always a kind of an American and worldly view of what a father feels about his firstborn son and what the expectations are, going all the way back to, well, you're going to take over the kingdom when I'm gone kind of thing. And it sounds silly, you have expectations of, oh, well, he's going to like this and he's not going to like that. And, the biggest challenge, and this really comes in any family, but it's even more of a challenge, I think, when you have an adopted situation, because they're not your blood, is that they're not going to necessarily be what you want them to be, and they're not going to do what you want them to do. And like I said, that's apparent in any family, but it can be even more so apparent in an adopted situation. And I think for me, it's realizing, look, he's just not into sports. It's not who he is. I love sports, played sports my whole life, but it's not who he is. So it's learning how to cope with that and recognize that, look, this isn't an adoption issue. He's just a different kid. He has a different personality. And once you can do that, I think, you learn to really love and embrace the kids for their own special talents and their own, special abilities. And Anthony certainly has his special talents and abilities, as do our other two as well. But once you get through that, then you kind of break down those barriers of thinking, even in terms of, oh, well, they're adopted. So I don't even think about that anymore. He's my son, and yeah, he doesn't like sports, but he loves to draw, and he loves to, sing and dance and be funny, and that's great. And he's going to bring a lot of joy to a lot of people.
I would say that probably the two hardest things are, you want to think as an adoptive parent, if you love them enough, that you can love them through it. I'm going to cry and it's going to be okay. And I think that Chris and I really felt that, especially with Anthony, we went through speech therapy, we went through the occupational therapy, and if we could just love him enough, we would make it better. And we really, that summer after we finished occupational therapy, it was really just, honestly, one of those moments that we had between the two of us, and one of the lowest moments we have for our family, because it's the recognition of, if we let this continue, just believing that we can love him enough without asking for help, it's going to destroy not only the two of us, but it's going to destroy our family. And being humble enough to finally admit that this is beyond us. But it is, and it's hard sitting, like Chris said, it's hard sitting in a doctor's office where they're going through the medical history and medical background, and you don't have answers because your child's adopted, and you can't figure some things out. So that was very hard. And I think part of it for me is, again, I think this comes from being a teacher, is that you work sometimes with kids that are different, and you see that they're treated a little differently, and sometimes they're shunned. And if there's anything, no matter what you want for your kid, it's to be loved and accepted. So the hard part of watching Anthony go through this process, and us go through this process kind of with him, is that him having a special need causes him a lot of times to be on the outside. And so as a mom, any mom, it just breaks your heart, because you want so much for your kid just to be accepted. And he already has a strike against him because he's adopted. And he already has a strike against him because he's Hispanic in a different culture, in our little pasty white town up here. And then to put on top of that, the fact that now he has a special need. Sometimes it just got to the point where it's overwhelming. Like, how is he ever going to find happiness? Or how is he ever going to make it? And so a big part of it was just changing our ideas of what it means to be that perfect kid. Because in his, and I think in our eyes, he's what God has chosen for us, and I wouldn't trade him in a heartbeat. So.
Well, I in terms of our emotional health, I think it's us working constantly to be on the same page and to be communicating and sharing our feelings with each other and how we feel, and most importantly, not being afraid to talk with our family and the people that are very close to us, who interact with us and our kids a lot, and help them understand, as we learn more, what it means to be an adult and give direction to someone like Anthony. I mean, understand. Look, you can't treat him like you would treat a quote unquote normal kid. Although in today's day and age, the term normal is skewed in so many different directions, right? I think that's the most important thing for us. And for him, I think, we have to do exactly what Emily, I think, was alluding to towards the end, is, again, finding ways to celebrate his successes. And this has been an especially difficult thing for me as the dad, because, I was raised in a family probably a lot like many, parents who's grew up in the greatest generation, grew up in the the 50s, 40s, 50s, and 60s, where it's about working hard. If you just work hard enough, you'll get through it. If you study hard enough, you'll do well on the grades. And and if you just sacrifice enough, you can become. Well, that doesn't always work. You can work as hard as you want. I can yell at him as much as I want. I can discipline as much as I want. It doesn't make him any better. And in some cases, it just withdraws him even to a darker place. And we've seen some of those very dark places. I mean, at 5 years old, he talked about ending his own life. Now, he doesn't necessarily know what that means, but when he says things that are talking about, swimming to the bottom of a pool and not coming up, there's a realization that, well, he must know that means that would cause him hurt and cause us hurt, so why would he say something like that? And you recognize yelling at him disciplining him, putting him in timeout, taking away things, this is not going to help our situation at all with him. So we need to find and we need to embrace every success that he has. And I am by no means a dad that believes every kid on every team should get a trophy. I am not one that believes that no one should get trophies except the best of the best. There's a happy medium, and you got to be, I think, flexible to find that. And with Anthony, we're gonna have to be gymnast flexible to have him feel good about himself, so that he doesn't feel like that outsider. And thank God we live in a good community, and he goes to a good school where he's found a couple of friends that. One of them is even similar to him, has tested on the autism scale, and he's got his own little quirks too. And they have found a very unique, interesting kind of Batman and Robin, Rain Man-like bond. And it's fun to see them together because they kind of understand each other a little bit. And they may be in third grade and act like they're in kindergarten at times, but I just always fall back on but what little boy doesn't, and maybe ours do a little bit more than others, but that's okay. We find happiness there.
I mean, I think we're realistic in understanding that, as a third grader right now, he spends, on average, where most kids, I think in his class, are supposed to have 30 minutes of homework. Anthony, every night, in order for us to get through his homework, it's about an hour and a half, give or take, depending on how much we have to redo from his day. So
sometimes less, sometimes an hour.
Less, sometimes,
But rarely ever 30 minutes. I mean, it's always longer than that.
So I think we understand that he's gonna need a little bit more support. Definitely looking into special ed programs. Definitely understanding that for him, his calling might be vocational school and not a 4-year college. And I think we're both really okay with that. I mean,
it's about finding what he's happy doing, and how he can be a productive member of society, and most importantly, get his emotions in check to where he's not a threat to himself or others. And we certainly have not seen that at this point. He is a people pleaser. He gets very upset when people are disappointed in him. He wants to do well, but if he feels like people are circling around him, or like the things are closing in, so to speak, he can turn pretty quickly, and he can turn pretty violently. And so that's what we're working on now, and getting him to not react so quickly, so violently, whether it be with words or physical action.
I would say our successes are in coming to terms and being okay with him being different. I think that was a huge hurdle in being able to say our son's, not only is he adopted, but he's adopted and he has special needs. It's hard, even to the other week, we went and he had another reeval by the occupational therapist as part of this process that we're going through, and she sent this 7-page document, and I'm reading it and I'm crying, and Chris looked over and he's like, it's not like you didn't know what it was going to say, what's wrong with the boy. And in a sense it is. I think sometimes it's just hard to keep having people look you in the face and say in black and white, here's your kid and here's all the ways that he's not normal or he's screwed up or a little different than everybody else. So I think a big part of this journey has just been learning to accept. I think a big part of the journey has been being able to step back and really honestly recognize again that we kept saying when Anthony first came home that it was so weird how similar he was to Chris, especially Chris, but the way he looked and sometimes some of our mannerisms that he seemed to pick up on and have. And I just remember many times people saying, or us saying, God really knew what he was doing when he chose Anthony to be part of our family. And even with a special need, it's neat to be able to step back and have that faith and say, God really knew what he was doing when he put Anthony in our family, and believing that with all your heart. So
I think he's definitely doing better. I think, as you said, it is a journey. Part of our challenges as we move forward is to, again, recognize that there's a balance. We certainly are not the parents, again, that are going to sit back and, roll into any kind of a principal's office and say, well, look, you have to do all this for our son because he's got all these problems. I mean, he has expectations and he has to live up to them, and, we're going to hold him to those. I mean, he doesn't get a free pass, but we are going to hopefully work with all of our teachers and family members too, again, in making sure that he gets the opportunities to handle handle the materials and life lessons at his speed and at his pace. And I think also going forward, one of the things that we have to work on in addition to that balance is also understanding the impact, and we really haven't gotten it yet, but the impact of what this means to our other two kids. Because he's the oldest, we're cutting our teeth on him every step of the way. Every time something new happens to him, it's the first time it's happened in our family, whether it's, the first overnight that he has at a friend's house or the first, thing that he does. And we're really in a dangerous place because we're setting a precedent to the other two who are so close to him in age, just 1 and 2 years behind him respectively, that they see the way we treat him, and there's a fear, I think, on our parts that they think that's going to be the way they get treated. And it's going to be a challenge, especially as they get older, and we're going to hear a lot, well, you didn't make Anthony do this, or you didn't tell Anthony he had to behave in this way, and it's going to be, Anthony's different. And how do you explain that to a 9-year-old or a 10-year-old or a 12-year-old? And they're not going to get it. And it's going to be a real challenge for us, and it's going to be a challenge for Anthony, because knowing him the way I know him, he will use it to his advantage, and he will try and get away with things necessarily that he can't get away from. So it's a very delicate balance of pushing him to continue to be successful, to continue to progress, to continue to keep his emotions in check, and that's the struggle we fight every day. And the other two have done, I think, a really good job. I mean, Anthony will get upset and cry and throw a pencil and say, I'm not doing my homework, and he'll storm away from the table. And the other two just sit there and kind of keep working. And they haven't tried that yet. And I think they realize that, in their own very strange way. And again, they're all adopted, and, they're from different moms, and they've all come together in this beautiful family that's ours, that God put together. And yet it's almost as if they know he's different. And he's not like everybody else. He's not like us. And he might be able to get away with that. But if I try it, it's not going to work. At least that's my hope, because if Nicholas starts trying stuff like this, it's going to be a challenge. But he's progressing.
They do a very nice job. Being so young, sometimes you forget, how compassionate kids can be. And there are definitely moments where Anthony will get upset or throw a temper tantrum. And it's not Chris or I who's the first over there to calm him down. It will be his brother or his sister.
Definitely his sister.
Yeah.
Ava loves going up to him and bringing one of his favorite stuffed animals, and patting him on the head or rubbing his back. And she's 6 and just kind of say, it's okay, Anthony, and it'll be all right. I mean, he's crying, and you don't expect to see that from a 6-year-old to her 8-year-old brother. But there's definitely a mothering instinct in her that she doesn't like seeing people upset, especially her brother, which is really nice to see. And I really want to get that stuff on video, because someday, it won't be that nice and simple. She'll be screaming at him to get out of her room and whatnot.
And now I would like to talk about medical concerns specific to various world regions. Most of the children from African countries are cared for in orphanages, therefore have a greater risk to exposure of infectious disease than children in foster families. Usually, the children are tested for HIV, tuberculosis, sickle cell and trait, hepatitis, and are given a complete blood count. Copies of these lab results should be given either at the time of referral or prior to travel. Common ailments for these children can vary from intestinal parasites, scabies, fungal infections, ringworm, and other skin ailments that are common in people of African descent, such as eczema or psoriasis. Many of these are treatable with either antibiotics or cream from over-the-counter to prescriptions. Malnutrition is a risk in African countries. Usually, serious malnutrition is obvious, as when Black children are malnourished, their hair turns an orange color. The rate of HIV in African countries in general is higher than in the United States and many other countries. The general information for risks in all international adoptions should also be considered for adoption from Africa. The health concerns of children adopted from Haiti are similar to those of African children. The children are cared for in orphanages, therefore they do have a higher risk of exposure to infectious disease and parasites. Malnutrition is a major concern due to rampant poverty within the country. Haitian women are known to mix dirt and water to form mud cakes and feed them to their children to ease the pains of hungry, aching tummies. HIV infection is high in Haiti and is a common cause that children are orphaned. The children should be tested for HIV before adoption referral is made, and the general information for risks in all international adoptions should be considered. For adoption of children from Central or South American countries, there are no specific medical risks that have been recognized in Guatemalan, Salvadorian, Colombian, or Dominican children after adoption. Physical and developmental condition reflects the type of care, whether foster or orphanage, and the quality of care received by the child prior to the adoption. The development of the child, physically, socially, and mentally, can vary greatly based on the quality of care the child has received. Most of the children from these countries will have had institutional care, although foster care is a possibility within some countries. Medical problems are more commonly expected in children who have resided in institutional settings, and a child is more likely to have suffered from abuse while in care when he or she has resided in an orphanage. Medical problems such as parasites, anemia, tuberculosis, etc. occur in small numbers of children and are more likely when the child had been institutionalized. Vaccine records and quality may or may not be sufficient, and the general information for risks in all international adoptions should be considered. As far as medical risk for children adopted from Asian countries, the type of medical risk is hard to say, as the quality of orphanages in Asian countries, including China, Taiwan, and Vietnam, varies dramatically. Foster care is becoming more common, and in South Korea, children for adoption are primarily cared for in foster homes. Special needs adoption programs, particularly for placements from China, Hong Kong, Philippines, and Taiwan, have become more popular, and the care provided to children with special needs has greatly improved over the last few years. It is not unusual for children with special needs to receive some occupational and physical therapies while in the orphanage setting. Malnutrition is a greater risk in poorer Chinese provinces and orphanages. Children adopted from China appear to have the greatest risk of any adoptive group to lead poisoning due to coal burning and lead-containing gasoline. Immunization records may be incomplete, and the immunization quality may not meet modern country standards. Generally, the risks of fetal alcohol syndrome and fetal alcohol exposure or effect are somewhat less than children adopted from Eastern European countries. Alcoholism does seem less likely in Asian countries, but don't forget the potential for alcohol use during pregnancy is a risk in any adoption. The greatest risk for fetal alcohol exposure of countries sending children for international adoption is found in Eastern European countries due to the higher rate of alcoholism in these cultures. The children available for adoption in these countries are generally cared for in orphanages. Therefore, there is a greater likelihood of exposure to infectious disease than for children cared for in foster families. Risks always exist for sexual abuse, especially with older children in an orphanage. Medical reports may be overanalyzed in the country of origin, and diagnoses may be uncommon to American doctors that are inexperienced with these evaluations from these countries. It is highly recommended to show your referral information and consult carefully with a physician specializing in international adoption if you are adopting from an Eastern European country. Malnutrition and emotional issues related to lack of food are not very uncommon in the very poor orphanages. The general information for risks in all international adoptions must also be carefully considered. Clearly, children arriving for international adoption have the potential for health problems. It is reassuring to know that most of these health problems faced by these children can be effectively treated with modern medicine, and this is the primary reason having a pediatrician well educated about the internationally adopted child is so important. At this time, please pause the video and discuss the following. Am I comfortable with the medical risks associated with adoption from the country I have chosen? Which risks am I most concerned with? Do I have access to an international adoption medical professional, or does the pediatrician I plan to use have great experience with international adoption? And our segment review. The internationally adopted child has unique medical challenges. Children cared for in orphanages are at higher risk than children in foster homes for infectious diseases. Children with prenatal alcohol exposure usually present with specific facial characteristics. Malnutrition is a primary concern in very poor countries. The quality and schedule of immunization varies among countries and with regard to specific referrals.